Hello and welcome today to a presentation on AI for sepsis. My name is Amit Shetty and I'm an emergency physician and a clinical director at the Ministry of Health in New South Wales. Today we're going to discuss why we think artificial intelligence is the way to go ahead for sepsis management and detection. And we'll go through the why, what and the how of this, what we've done in New South Wales, Sydney, Australia. As you know, Sepsis 3 has redefined sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. We also know that it's difficult to diagnose due to the myriad of symptoms and vagueness of these symptoms. A lot of the symptoms that occur with sepsis are non-specific and can be present in absence of sepsis. And some patients with sepsis might be relatively asymptomatic or very vaguely symptomatic. Now, the other new challenges we are finding in clinical practice is that non-continuum of infection, sepsis, and septic shock, and our patients can move between those stages as well. And sepsis might not be a static state, but a dynamic state based on our interventions, especially noted in our inpatient settings where patients might be on chronic antibiotic use and develop a slow cold type of sepsis. All in all, we do know that delays in the detection and management of sepsis leads to poor outcomes for these patients. And the figure on the right shows you that this results in a significant cost for infection and sepsis to our communities and patients in Australia. So why AI for sepsis? Sepsis definitions have changed and keep changing regularly based on increasing knowledge of the pathophysiology of sepsis. We know there are no single sets of signs or symptoms, no single biomarker, and there are a lot of mimics for this sepsis. One of the key issues as we move across with sepsis detection is our current view on binomial threshold. For example, a pulse of 120 plus can be considered as SIRS positive, but someone with 119 may not be picked up as a SIRS positive patient because of the binomial thresholds. Whilst we also know a blood pressure of 100, which is considered to be a significant threshold in detection for hypotension, may be a normal blood pressure for a significant amount of our younger or youth population, whilst the same threshold for elderly population might represent a significant cardiovascular impact, or even 50% of their normal blood pressure, which could be even in age groups more than 70, could be a systolic blood pressure of 180, which could be a normal for them. And this results in a significant risk of harm at both extremes of age, plus in patients who are on medications who might not have the symptomatology or have altered physiology. All in all, it's just way too many variables of when it comes to diagnosing sepsis. There is the clinical variables, the variables which might flag as dysfunction in the patient, but also the clinical conditions and chronic conditions that put patients at risk of developing sepsis. Senior clinicians do this regularly on the floor, but as we know, this is not uniform across all sites and all presentations and all times of the day in our emergency departments across globally. And there is also a significant opportunity that lies with us with electronic medical records and digital technologies. Though I have to point out that electronic medical records and alerts have noted to date yet to be proven to have significantly improved care of sepsis, except for some small pockets in studies, but also do result in alert fatigue, static and workflow issues, and also seems to rule out the clinician gestalt and the patients in those gray zones. So the implementation, in short, the implementation of binomial threshold-based clinical pathways in electronic medical records without the complex technical architectures to capture clinical information around risk factors leads to significant alert fatigue and also potentially not significant higher improvements in sepsis detection and management. I have to highlight here that EMR alerts don't necessarily are the be and end all of all digital technologies. So we decided that we decided that we needed to look at the novel data and digital technologies to design a system to be able to detect patients with sepsis. What was interesting, though, was when we started this project and we decided to take it back to the clinicians on the front line, the key feedback was it wasn't the septic shock patients who presented to them, which was the issue, but it was an undifferentiated patient waiting in the waiting room who was at developing risk of sepsis or didn't present with acute sepsis, but a delay in their diagnosis or in investigation would lead them to quickly have a slippery slope and probably adverse outcomes. We had significant human-centered design team engagement, and we decided to pivot the program from diagnosing sepsis to finding the highest risk cohorts of sepsis who could benefit from early investigations and potentially early interventions as well. The project was sponsored by EL New South Wales and supported by the Hospital Network and the Department of Health in our state. So the aims of the proof of concept project was to develop a clinical decision support for clinicians to identify patients in the ED waiting room who are at risk of developing sepsis. And we aim to get early interventions in these patients and hopefully reduce ICU admissions and death related with sepsis. So in short, we plan to make a sepsis dashboard which could be used by the triage and the nurses and early in the journey for patients in the waiting room who potentially could then be expedited for care. So we decided that we need to develop an historical cohort through which we can develop the models on. We extracted digital data from the emergency departments for 4 different hospitals for 3 years. And these included the entire patient journey details of these patients. We labeled the sepsis 3 definition outcome variables, and we fed it into data science models to then define what was decided as sepsis or non-sepsis based on the sepsis 3 criteria. As the data on the right suggests to you what was the data in the EMR we wanted to. And as the aim was to look at models and develop models for patients in the waiting room, we wanted to only include the variables which were available readily at triage to be used to define a risk model for these patients. It wasn't about including all their investigation results because those results are not available at triage or in patients generally in the waiting room area. This is a high system level in architecture diagram of how we extracted live data from the EMR, and these data are fed to cloud-based architecture where the data models and the prediction models are run on every single patient based on the information available at triage, and that then develops a risk score. One of the key findings for our risk scores was the clinician view on not approaching sepsis as a yes and no criteria, but a traffic light system. So they could actually use that gestalt and also potentially also have a triaging system of seeing who was at highest risk and who was at least risk rather than a diagnosis-based approach to clinical decision support. The second diagram as well highlights the deep dive on how these results were passed through using the AWS architecture. So essentially, this highlights the clinical workflow for the patient. So patients who arrive in the ED and on registration usually would get triaged. The ones who get triaged as septic shock and go category resus 1, go to the triage base, resuscitation base, are usually not the problems or the risk which we were planning to risk because they were getting early senior review. It's the patients who received the triage criteria, probably potentially not in septic shock or have high risk criteria, and are getting triaged and have been asked to wait in the waiting room to be seen by a clinician. At this point, we would collect all the data, live data streams from these patients. Whilst it does it for all patients, these are the particular patients where they then populate into an at-risk patient dashboard for the senior flow nurse or the front of house nurse who sits near triage for general flow issues for the patients in the emergency department. This can also be used to then flag which patients can be seen by our early physician at triage model for investigations and potentially a senior physician risk assessment, so the risk can be down or upgraded based on their early review of this patient. Here's a script of how I've done a picture of how the dashboard looks and how we also flag The other issue which we found in a lot of patients during presentations is the incompleteness of the variables such as vitals at times, because these are done across a glass window. And these might then just be helpful for the clinicians to decide what is the next intervention to do in these patients. Like in certain patients, if the patient needs to get the next sepsis pathway intervention as it's available on and in our departments for patients who meet the criteria, or if patients require certain investigations so that it can be recharacterized or the risk can be further refined to decide if the patient does have the organ dysfunction or whether this patient can be downgraded back to a lower category of intervention. So our historical analysis showed that around 112 ED presentations met the sepsis 3 criteria, suspected infection plus organ dysfunction of 2 or less. But we also included the patients who developed, who had a discharge diagnosis or the ED diagnosis of sepsis and had not been picked up by the initial rule. And typically our dashboard suggests 6 to 12 patients with red alerts, which again for a 200 to 50 patients a day census is about the right ones. But it still does have a significant false positive rate. And the key is not about fixing, and that's why the red and the traffic light system aim to pick patients based on risk for the ones who were with the highest risk of a higher specificity for the red zone patients, and a very high sensitivity for patients who are in the green zone patients. So then we don't have a low false negative rate for the highest risk patients and a high false positive, not a very high false positive rate for the green low patients. This, in short, shows us all the different models which we run on the data streams and which would be able to suggest to us which were the models we need to use for predicting. And these are the live reports that we are currently capturing on all our patients who present during the project, so we can actually look at the track and see the changes in ordering practices or practices in interventions, and also the count of deaths on these patients as well. So in short, what we've tried to highlight here today is that novel digital and data science technologies are able to probably augment clinical practice, but they have to be designed to meet the clinical practice need, not for an outcome of sepsis. The other thing which we realized with clinicians was that it wasn't the definition of sepsis that was driving their care models, but the risk of harm, such as risk of blood culture positivity, risk of admission to ICU, risk of need for IV intubation, risk of IV antibiotics, risk of long length of stay, or risk of death in hospital from an infection. These are the outcomes that we need to tailor for our sepsis screening tools rather than a specific definition of organ dysfunction. And we also realize that as this technology is evolving and the trust in these technologies has to be built, these have to be closely built around augmentation rather than automation, and can't be a yes-no rule such as sepsis present or absent, but has to be a graded approach to like the 3-signal light system that we have adopted. It always needs to allow for patients to be added to this, the pathways through clinician gestalt, and also in case of pediatrics, parent gestalt as well. This was clearly a very good partnership between data science, information technology experts and researchers to develop these acceptable working algorithms with their clinicians. I would really highlight that this is a clinician-partnered intervention rather than a traditionally, which is spoken in literature, on clinician-led. I don't think these projects can be led by one single group, because every single group brings in a specific knowledge skill to this group as well. Irrespective of that, sepsis remains a difficult diagnosis to make at a point in time due to the dynamism of those findings, and maybe it is that close monitoring of those high-risk patients that is required. And this is not a one-step journey. These models have to be iteratively evolved, and there needs to be a flexible business architecture, which our current EMR systems don't provide, to be able to approach. It's the ability to set up live data streams to a cloud architecture that allows us to use different data models to predict in different age groups. And we found that specific data models and data science models seem to work better in different cohorts of patients. In any case, any of these models require translation and implementation, and which requires significant staff engagement, especially when the novel technologies are not as trusted. The clinician has to be a part of the journey all through it as well. It's a co-design approach that has resulted in significant improvements in those models, and we continue to accept feedback and ongoingly evaluate the performance of these algorithms, because that's what develops trust in these models. So thanks for hearing my presentation, I would like to acknowledge the clinical teams from the Western Sydney emergency departments who have worked together with all the data science and the ICT teams from Western Sydney, IE Health New South Wales, and the Biomedical Engineering and Digital Health Alliance group at the University of Sydney, who helped build these models for us as well. Thank you, and that's the end of my presentation.